Good morning, everyone, and welcome to the Bipartisan Policy Center on this rainy morning to talk about medical innovation and real-world evidence. I'm Bill Hoagland, a Senior Vice President here at BPC, and I have the pleasure of overseeing our economic, fiscal, and health team work here at the center. At BPC, we honestly do try to take the best ideas from both parties and promote bipartisan policies to improve health, security, and opportunity for all the Americans that we can. Today's event is being hosted by our Health Innovation Initiative led by Janet Marcher-Broda, its director. We will be taking questions later in the program. If you're watching us online and you have a question for our panelists, you can use hashtag BPCLive to ask it, and we'll get to those questions during the Q&A session. Today we're focusing on the important role of real-world evidence, data drawn from clinical settings, health plans, and even patients themselves, and what role big data plays when it comes to drug development and regulatory approval process. I was struck by some recent statistics I read in an article from the authors of Big Data, a revolution that will transform how we live, work, and think by Kukier and Schollenberger. They said, and interesting, that as recently as the year 2000, only 1/4 of all the world's stored information was digital. And today, less than 2% of all stored information is non-digital. Some staff would say it's all in my office over here, by the way. This amazing revolution in digital technology, biology, and science is transforming how medicine is practiced, how cures for previously incurable diseases are being discovered and delivered. With that, I'd like to move quickly and introduce our first panel. This is a particular privilege for me as I get to introduce my two favorite U.S. senators and congressmen from the volunteer state. This is going to sound like a Tennessee stacked panel, and it is, since the senators and congressmen are also going to be joined by another Tennessean, Doug Oliver, with an amazing story to tell about modern medical science. Finally, sticking to the Tennessee theme, let me point out that one of our BPC's founding fathers here was the great Senator Howard Baker, who I had the privilege of working with when he was Senate Majority Leader. I know Senator Baker would be proud of the dedication these gentlemen have brought to this issue and all the public service that they've provided over the years, particularly Senator Alexander. It's not in your bio that you have, but you might know that Senator Baker's first Senate staffers was Senator Alexander before he became Governor, Secretary of Education, and then Senator himself. So without further ado, please join me in welcoming Chairman of the Senate Help Committee, Lamar Alexander, my last boss in the Senate, Senate Majority Leader Dr. Bill Frist, former Congressman Bart Gordon, both who chaired our initiative on advancing medical innovation, and our real special guest, Doug Oliver. Tennessee gentlemen, welcome. It sounds like a bourbon, doesn't it, Tennessee?
I'm Bill Frist. Let me welcome everybody. We have really about 35 minutes, so we're going to jump right in, but appreciate everybody being here to review, introduce, elaborate upon an issue that is among the most important issues today in the field of science, health, healing, medicine, as we look to setting a platform for the future. We do have with us, as Bill so aptly introduced, three figures here who are instrumental in many ways of setting this foundation and looking ahead. So let me jump right in, and we'll have just sort of a free-flowing. I'll be throwing some questions out, and then we'll turn to you. But Lamar Alexander, Senator Alexander, Chairman Alexander has led on this effort. And Lamar, why don't I open with you so you can review a little bit about what you've been up to. But I know early on, when we first started talking this about 3 years ago, the discussion did center around this being among the most impactful legislation that the body of the United States Senate because it can literally affect everybody. Why don't you take it from there, bring everybody up to speed where we are, and what your view is of the importance of this legislation?
Well, I'll do that briefly because I want us to have plenty of time to hear Doug Oliver. So that's right. Bill Frist said that the legislation we're working on, which we call 21st Century Cures, could be the most important legislation that the Congress acts on this year. Yesterday, that's one majority leader. Yesterday, another majority leader, Senator Mitch McConnell, said the same thing. The reason is because we're in such a breathtaking moment in terms of biomedical research. And Congress is stepping up last year with its additional money for NIH, a big increase, 5 or 6%. The Senate committee is doing that again this year. And then the 21st Century Cures legislation, which the House passed last year, is basically to work on another set of problems, which is how do we get these treatments and discoveries and medicines through the investment and regulatory process more rapidly into patients' lives and the medicine cabinet. So that's why it's so important. It affects millions of Americans. Dr. Collins has talked about the next 10 years and artificial pancreas, hearts that are rebuilt by, rather that we put Bill Frist out of business.
That's right.
As a transplant surgeon, hearts that would be rebuilt by your own stem cells, non-addictive pain medicines. The opioids kills so many people more than die by gunshots or car accidents in Tennessee. So where we are today is that the House has passed and the Senate has nearly finished its work on the 21st Century Cures, and we're in the midst of discussions between Majority Leader McConnell and Speaker Ryan about how to finish the job. And one of the aspects that we hope to deal with has to do with the story we're going to hear today. It's how do we take another effective, significant, responsible step toward providing more opportunities for Americans to have the same kind of experience with regenerative medicine, using their own stem cells out of their bodies to help restore their eyesight or them in some other way. The same experience that Doug has had, and there are 4 other colleagues of his who were in the same study treatment in Florida who've had a similar sort of experience.
So the impact, the potential impact really comes down to this sort of intersection of having the appropriate pathways with the safety and efficacy and all the traditions of the FDA continued, but modernized because this regenerative medicine is new. And the FDA is not new, and we love the FDA, and it's done a tremendous job in protecting all of us. So how we go about that, and that's where the legislation came from, the human side and the reason to be, and as a clinician and as somebody who does do heart transplants and has done hundreds, taking them out and putting them in, it's going to be unnecessary in the future, so why don't we just bring the future to today since the science is there? Is the science there? And I think it's driven home most by yes, and we need a lot more research as we go forward, but it really does start with a voice, and the voice is a patient, and the patient is with us today, and that is Doug Oliver. And Doug, because we're from Tennessee, and we all happen to be from Tennessee, Doug wrote me an email a year and a half ago and basically said, you're on it, you're onto something good. I raise my hand and I will be able to give my story. Doug, what about it? What happened to you? Tell us, you can keep it fairly short because I want to come back and ask sort of the why behind it, but give us your story.
I had actually come with somewhat of a planned kind of initial beginning, but about a half an hour ago, my brother texted me and reminded me that today is the 10th anniversary of my mother's death. And so I thought maybe I'd just start with that. Yeah. Because I inherited my disease from my mother, and she didn't know she had it. Neither did the doctors who tried to diagnose it. She was diabetic, and she started losing vision very slightly, and she became afraid and went to an ophthalmologist in the Willywax of northern Maine, and her kind physician basically said, it is not diabetic retinopathy. And she called me on the phone with a big sigh of relief, I remember, and told me it wasn't. there is something she said, but don't worry about it. And we hear that a lot.
Yeah.
And that's okay. Perhaps that would have been the best advice for Mom. But I have an inherited form of dry macular degeneration that I inherited from her. It acts a lot like age-related macular degeneration. It's noticeable by different patterns of damage that match each other in my eyes. And it started affecting me at about age 32 when I went to get a new prescription for my glasses. And my optometrist said, "You're too old to need a new prescription for your glasses. You need to go see an ophthalmologist." And from there, I was diagnosed and began my journey of trying to figure out what my life would be like, because my disease is called Maladia leventinese, or autosomal dominant Drusen syndrome, would be the more modern name. And essentially, it's a disease with no treatment, no cure, and really no hope. I could look forward to becoming legally blind by the age of 60. And the doctor that told me that happened to be the one that I visited at Vanderbilt University when I first moved to Tennessee. And I remember sitting in the office simply stunned, and I don't have tunnel vision, but at that moment, I got tunnel vision. I felt like this wasn't real. This wasn't real. And but the physician at the time said, "There's no treatment." He said, "But I want you to pay attention to a couple of things that are going on that might offer a little bit of hope." And then he said, "Your answer is not going to be genetics. Your answer is going to be stem cells." And he advised me to go on the World Wide Web and visit clinicaltrials.gov every so often, and that if he saw something, he'd be calling me. I did my due diligence, and about every 4 months, I would go on clinicaltrials.gov. And over the time that I was looking, you could see more research being done on macular degeneration, and I was very encouraged, but nothing for inherited macular degeneration. And so when I discovered a clinical trial a year ago in February that offered to work with a population that might have inherited retinal diseases and optic nerve injuries and conditions, I got tunnel vision. And it was like, is this real? I had been doing my research for several years, and so I inquired, and the clinical director said that he would like to see my medical records, and I sent them down, and 2 weeks later, I got a letter back saying that I had been selected for the study. It's really more of a treatment study. It's hard to describe that in the big data, if you want to say that, that explains clinical trials. And I think this particular treatment study is going to offer data that does start at the threshold of real-world evidence. That's an example. They have included international research. They've embraced some of the more positive outcomes. We hear horror stories, and there are horror stories, but in general, we all know, it's like a proverbial medical elephant in the room. We all know that this type of treatment is really working, and people are really benefiting. Athletes do not get shots in their knees after an injury and go to work in 2 weeks. So we know this. And I call that a false consciousness. And so I think one of the barriers, if you will, and I know we'll be getting into that, but from a patient perspective, one of the barriers is it's a cultural barrier. It's not a scientific barrier. We as people in society, we want to hold something as a truth. And what is not true is that cellular therapies don't work. And I'm an example. So I went for the treatment which involved aspirating bone marrow out of my hip, my own bone marrow, and gaining enough volume, and there isn't much needed for eyes, obviously, but gaining enough volume of the CD34 plus stem cells that like to turn into retinal cells in animal studies and in treatments abroad. That is put in an FDA-approved centrifuge, spun out, separated from other components like nerve growth factors and plasma elements and, you know, the nutritive and supportive compounds that are already in bone marrow. It's separated out. Parts that are wanted are reconstituted into a cocktail of sorts, put in a syringe and injected in my eye. There were no petri dishes, no culturing, no drugs, no genetic manipulation, just a simple, special centrifuge.
Doug, let me jump ahead and outcome to you, because you really didn't know coming in, and because we don't have this sort of appropriate track till we have a lot of clinical trials coming in. So you're really pioneering there. But what has the outcome been?
The outcome was I went into an operating room, class 1 operating room that had an orthopedic surgeon, board certified, retinal surgeon, board certified, anesthesiologist, board certified, and an interventional radiologist to guide the needles and an orthopedic surgeon to take the bone marrow. And that is what happened. I had blindness in this eye at 2,400 and blindness in this eye at 22,000. So this was my worst eye, and I was given a dose of stem cells underneath the retina.
Yeah.
And in this eye, I took a less aggressive treatment, which would be a proper medical protocol, and that was injections around the eye in different areas and in the eye.
Okay, let me jump ahead just because we're going to run out of time here.
Oh, okay,
Outcome has been what?
The outcome is the next day my peripheral left vision kicked in. 2 days later, my right vision kicked in. I saw 3D for the first time, and in December, 8 months later, I got my Tennessee driver's license.
So it's an unbelievable story. It's remarkable. The thing is, it shouldn't be unbelievable and remarkable because the science is there. And I had the opportunity about a month ago, to go to at the invitation of the Pope, to the Vatican Council on Regenerative Medicine. And we had scientists all over the world. It was interesting that there were more scientists from Germany, Italy, and other countries than there were from here. But the reason is that we are lagging behind in developing an appropriate pathway to, in a rigorous, science-based way, look at these sort of instances. But I think it's sort of living proof. It's there. You go around the world, and a lot of people in the United States go overseas. We just shouldn't be doing that today. That's sort of the purpose. Bart, you and I have been sharing a different initiative, of which this is a subset, on innovation here at the BPC. When you look and hear this, and you know our innovation package, give that larger perspective of how you look at something like this in view of innovation more broadly here in the country.
Well, you know, I hadn't heard Doug's story before, but it's what we call putting a face on it. And my 90-year-old mother has dry macular degeneration, and she's legally blind. And so I have to call every day to make sure everything's fine.
I know the story.
And I go down there once a month to pay the bills, change the light bulbs, do whatever I need. And I'm sure that everybody here knows somebody, not necessarily with macular degeneration, but has some need.
Everybody's a real world.
Yeah,
Yes.
right. And again, this is not hypothetical. This is the real thing that will impact all of us, either personally in the sense ourselves, or someone that we know. So I guess two observations I would make is, Senator Alexander, thank you. We're at the Bipartisan Policy Council, and you demonstrate that a courteous, respectful, bipartisan dialogue can lead to legislators doing what they want to do, and that is to pass constructive legislation and not just agitate. And it impacts all of our lives. So thank you for that. And I guess one other, since we have a Tennessee theme here, the base legislation, FDA legislation that we're talking about was as to ski offers over 50 years ago. And I'm sure at the time that they were doing it, they wanted to they wanted to be sure that drugs could be brought to the market safely and that the public had, a confidence in that. And that's what this legislation wants to do. But I think we also need to keep in mind there's a little bit difference in that now, the fastest growing part of the budget is healthcare. And the fastest growing part of everybody's personal budget or business budget is healthcare. And the price of drugs drives a lot of that. So, hopefully some of the recommendations that we put forth and that you have put in your legislation will not only provide that safety, but also will help us be more economical so that we don't kill the goose that laid the golden egg.
Lamar?
Well, that's right. And when sometimes we do just talk about money at things like this, which is why it's so important to have Doug and his colleagues here, because these are personal stories. But we are talking about money. I mean, Bart just mentioned the three biggest drivers of our medicine, and Bill, correct me if this is wrong, I suppose, today are Alzheimer's, obesity, diabetic, and heart disease are probably, and all three of those, according to Dr. Francis Collins, we have a capacity to identify Alzheimer's before we see the symptoms or to delay the onset. That would save tens of billions of dollars. He sees that coming in 10 years. The artificial pancreas would be an enormous lifesaver for many people, but it would save a lot of money in terms of diabetics, and then Bill's the expert on heart disease. So there are costs to this, but the costs in just financial terms are much less than the savings. Dr. Frist took me to Africa in 2003. I went back last month and saw what's happened with HIV/AIDS with the $15 billion that Bill Frist and George W. Bush arranged to help with HIV/AIDS. The most startling statistic when we were there, Bill, was that 40% of the mothers with HIV who were infected with HIV were infecting their babies. Today it's 1.7%. So think of not just the personal story with that, but think of the money that saves for those babies' lives. So it has to do with money, and it's a very exciting time.
I think the history is interesting in that, going back to the HIV, and you see the dramatic impact where there are 10 million people alive today because an investment was made at the governmental level and a structure was set up. And that's really what we want to do with the FDA modernization, is really have a structure set up where you can have the appropriate research and execution implementation of what comes out of that research.
I think one thing, not to interrupt too much, but
Yeah.
particularly with your background in transplant surgeries, I imagine at the beginning of that there was skepticism and worry about
you're
that.
exactly
but
right.
we need advice about how do we move ahead with this and avoid the horror stories so
Yeah.
that the horror stories don't derail the stories like Doug's. So that's some help we could use.
When we started doing heart transplants out there, it was very new, and that was very, very expensive. And in truth, people said it can't be done, it won't be done. Even in Boston in 1981, we put a moratorium, or they put a moratorium on doing heart transplants totally, and it set back the heart transplant world in Boston 10 years. That's what's kind of happened with stem cells because of a different reason. It was an ethical consideration back when I was in the Senate. It was embryonic stem cells versus adult stem cells. Now we don't. We're not talking about the embryonic stem cells. So the ethical roadblocks of 12 years ago are no longer there. And now that they're not there is the reason that we can accelerate with the legislation and your leadership, come to the point that all these hundreds of transplants that I've done in the past, not just theoretically, but they are going to be unnecessary in the future when you can take a cell from your own body, an adult cell, you back it down to become a pluripotent cell, and then you shoot it back out to become a heart, and that's exactly what happens with Doug Oliver. And he's a manifestation of that in the eye, not the heart. That's the science. Now we just need to modernize and bring up to speed this overall structure. And that's the excitement about it, the passion about it, and it's here before us. with the House having moved and with the Senate moving and with all our broad support, again, in a way that is respectful of the safety and the efficacy and the protection of the individual patient themselves. Yeah.
One theme that runs, I guess, as former chairman of the Science Committee and having worked with Chairman Alexander on the RP and a variety of things, is innovation that runs through this. And innovation really is, we have to invest in research. Research then provides new technologies, new types of commerce and products that then provide us additional revenue to invest, once again, into research, into education, which cuts across all these areas. And certainly health is a prime example of that.
Lamar, I guess let's take one or two questions. I know at some point you need to go work on your Senate. If you want to slip out now or later.
I'll wait 5 minutes and then I'll go while you all are still going.
We'll spend another five minutes here with this. But at this point, are there questions with Doug here, because it's rare to have that opportunity to talk to somebody, and I can ask him other questions and get the answers. But are there questions from the audience while four are here? Or thoughts or
I've got a question. Can a 90-year-old woman that is legally blind, is it too late for her?
Not if she's healthy for general surgery.
Well, that's the problem about being blind for a while. You know.
Health goes down.
Yeah.
That's right. I do know that there are treatments that are not using general anesthesia, so those would have to be researched.
Doug, what's been the most, as you have gone around talking to people with your story, because we haven't had this structure, there are not a lot of people here with your story,
Right.
And so you're literally opening people's eyes to this whole field, because you're a manifestation of that. What has been the reaction as you've gone around telling your story?
This one.
Yeah.
That's the most common.
Yeah.
There are other stories. I'm all a geek about the science of it. I enjoy it. And most patients do a lot of research before anybody touches their eyes. So, I receive all kinds of actual questions, but the biggest one is not about the science, and I don't like that. But the biggest one is, how does it feel?
Lamar, the other big area is sort of the information sharing, and this will flow into the next panel to a certain extent. But in this day and time, compared to 15 years ago, where people such as myself didn't have access to big data, real-time data, the collection of sort of crowdsourcing data, where you've got millions of people out there, we just couldn't collect that data. We'd wait till we fill out a little form if there was a side effect and send it in some way, and it may go through the system. What have you learned in terms of having the hearings, of the importance of this big data, sharing of data, transitioning data, especially as we go into this rapid pace of science where it's moving so fast? $2 billion, 10 years for a drug clearly is not what we should be doing today.
No, well, what I've learned, number one, is that personalized medicine, which the president calls precision medicine, won't work unless we have better ways of handling data. I mean, it just doesn't help to gather big mounds of data that nobody can go through. I mean, you imagine if you want your medical records taken from hospital X to hospital Y today, the best way to do it is to go dig it out of the basement in hospital X and put it in your pocket and carry it to hospital Y. That's the only way you can be sure that it's going to get from one doctor to another. So it won't work, particularly as we begin to get into individualized treatments for so many different diseases. And second, what we've learned is that the $30 billion that the government spent on electronic healthcare records wasn't spent very well. So we had 6 hearings on it, and the 21st Century Cures legislation in the Senate has a lot of steps in it, working with the administration, try to get that back on track, because it's so important if we're going to get 1 million genomes and begin to get all this information. And then I've learned in Nashville, if you pardon another, Tennessee, the hospitals have decided, look, we're buying $100 billion of stuff every year. We're getting tired of the vendors telling us what to buy. We think we'll tell them what we want them to buy, and we'll create a platform into which data and devices can plug. So create whatever you want, but it's got to be able to plug into a common platform so your hospital room doesn't look like a jungle zone with red lights going off all the time, and so the data that might be in 5 different hospitals can all be assimilated. So that's what I've learned about data in the last year and a half, and that's an important part of the 21st Century Cures legislation.
I hope you will incorporate this into that. National Institute of Standards Technology, they have the ability in terms of aggregating, in terms of interoperability, they can be a tremendous asset here, and they're waiting to participate.
I think, again, just to review, and I know most people know this, but kind of bringing things to a close in terms of this panel, Lamar, your leadership has really been instrumental in getting to where we are today. We still have to get across the finish line, and that's something that collectively we can do by having the real stories out there, looking at the science and looking at the FDA, preserving its greatness, but modernizing it. But just to summarize, Lamar and the Health Committee has put together and I guess approved over 50 bipartisan strategies in 19 different bills, which is a strategy, a very smart strategy in ushering the overall legislation through. And all of it centers around this acceleration of this drug, in part drug, but also device and regenerative medicine, to be able to accelerate all that in a modernized way. There in that are several activities designed to advance the President's Precision Medicine Initiative that Lamar mentioned, actions that will improve the scientific expertise and the experience and the capacity of the Food and Drug Administration to actually strengthen the FDA, clarification of the consumer or each individual patient's rights. To clarify that is in the legislation that he's written. The information sharing, we mentioned the interoperability, which is so critical to have a seamless flow of information where you have data. Actions in those bills that give regulatory clarity in a way that the ambiguity and the fog, as much as we can today in terms of policy, is eliminated. And ways to ensure the perspective of the individual patient, which in policy is sometimes hard to do because you're dealing in the aggregate. But the legislation really does look at ways to protect the individual patient and make sure that those perspectives, and I'm sure Mark will talk about that later, are in the process. And just closing from the BPC would work in a more macro perspective, in which Bart and I work on. A majority of the legislation in the package was included in our recommendations to Chairman Alexander and to Ranking Member Murray, who Chairman Alexander works with very, very closely, and the Health Committee, all of which was issued last July. And in parallel to that, in support of that work of Chairman Alexander, here at the BPC, we launched it was called the FDA: Advancing Medical Innovation Initiative in early 2015 to really support the initiatives that were going on in Congress and inform the medical innovation cures efforts. And we brought together here national experts. We have interviewed hundreds of key stakeholders and published our findings in a series of reports, the latest of which we're releasing today, and that is the one on real-world evidence that I just mentioned. So, as Bart mentioned, we're at this in a bipartisan way in this process to find consensus strategies that focus on the patient, meet the needs of the patient in a modernized 2016, 2017, 2018 time frame. It's an exciting time. We have this convergence of the House and Senate legislation, and Lamar's leading that in the United States Senate, working in a bipartisan way, working closely with leadership. But we have that going on. We have the President's Precision Medicine initiative going on, and then we have the Vice President's moonshot. We're at that convergence. It's a moment in time that we need to capture, we need to seize. And with that, we'll close out this panel. But Lamar, thank you for your tremendous leadership.
Well, Bill, and I should be thanking you, but you wonder, I guess, sometime if you're outside the Congress, if the advice you're giving us makes any difference. In this case, it does. I mean, the leadership of the Bipartisan Policy Council has been parallel to this effort in the United States Senate for the last year and a half. Your papers, your working groups, your experts give validity to the kind of thing that we're trying to do. They put the spotlight on it, and in many cases, they've given us specific ideas that make sense that are incorporated. So thank you very much for it.
Good. Thank you, Lamar. Doug, Bart, thank you, and to the BPC and everybody in the room, thank you as we march ahead. Appreciate it. Thank you.